Dave, thank you so much for joining us this morning.
It's a pleasure.
And we said that we would talk a little bit about your experience of your own health and some of your experiences of working with other men who have prostate cancer, just to give people a bit of insight into what it's like. So just to start, can you just tell us a little bit about yourself and about your personal experience?
Yes, of course I can. Diagnosed in May 2011, unfortunately beyond surgery, because the cancer had spread. And since that time, I've devoted myself to helping people that suffer with prostate cancer. And I helped start the Oxfordshire Prostate Cancer Support Group in Oxford, which today is still very strong. And I'm actually the president of that association.
And that's part of how we met, was through the work that you'd done to set up this fantastic support group.
Absolutely.
And the other thing I remember is that you did a video of what it was like to go and get treatment.
Yes. So with the video, it's accessible. When it first started, 10 years ago, it's called Day's Journey on YouTube. It was the only Day's Journey there was at that time, but there's quite a lot of Dave journeys now. So it actually shows the total experience of going into the radiotherapy department at the Churchill Hospital all the way through. And the video was actually taken on the 37th, the last and final treatment at the Churchill. It's had over 16,000 views, and it's helped so many men and their wives, their partners and their families.
And just tell me a little bit about what prompted you to do that? What in your own experience made you think, I'm going to go with a camera and show people what this is like?
Because anybody facing radiotherapy, whether it's for their ear, their tongue, their neck or whatever, the family doesn't know what happens with the radiotherapy treatment. And it's so simple, and it's nothing particularly frightening. And that's the experience I wanted to share. Because when people have the radiotherapy, their family are all concerned of what's actually happening with that process. And there is nothing to worry about that process. And that is very clear, comes out in that video.
Yeah, that's what I remember about it, is that it was just you with walking through and saying hello to people along the way and just showing people exactly what it was like. And I was so struck by it. I encouraged some of our other colleagues to make similar ones for MRI scanning, and the things that, might seem a little unusual for people to go and do and be in a hospital, because most of us don't go there on a regular basis. So I think that's really important. How much information had you been given about what it would be like?
Well, it's an interesting one. I often give talks to groups of people, and the first thing I kick off with is hands up, all those people that don't like sex. I've never had a hand go up, and I can see everybody on the screen, they're not putting their hands up. Everybody loves sex, but they don't talk about it. And I think that from May 2011, a big part of me died, because the prostate gland is a very important organ within the body. And any treatment with that will give you a very good chance of ending up with erectile dysfunction, like I have erectile dysfunction. The problem I had was, as far as the medical teams were concerned, they did a magnificent job. But they did fall down on not being able to give us the possible outcomes of what these treatments would necessarily be. So as far as I was aware, by having radiotherapy, I'd be spared the prostate nerves. Be able to carry on life as normal. Well, that didn't happen. And stupid things like, the prostate gland manufactures all the fluids to help the process of making love, making babies, whatever. That's gone. because if the prostate is removed or radiotherapy or whatever cause, that stops. So when I say a part of me died, that's really very true. As far as I was concerned, I was probably above average normal, enjoyed a very happy sex life, and it all came to an end. As soon as I took female hormone treatment, I wasn't aware of that at that stage, that would happen. So it's not just about my situation. We have to consider the mental being of the wives as well, because they're forgotten in the whole process. And I don't know what needs to be done. I think that before anybody has treatment, they should be given the facts 100%, so they are aware of what is going to happen going forward. So I think that the way forward is watch and wait with people. I think even since my treatment, there's lots of new processes, lots of new ideas. And the other sad thing, which is not available to the normal person, is there are treatments, good treatments outside the NHS, but people are not told about them. They don't know about them. And as far as I'm aware, it's because the equipment is expensive. You need the trained technicians to be able to operate them. So hopefully that will change going forward in the future. And in my view, would save billions of pounds to the NHS should they adopt T3 scanning, etc., where you can have treatment one day, stay overnight, catheter removed the next day, and you carry on a normal life after that.
Dave, can I just ask? I mean, when I first met you, I was always very struck about your very sort of, frank discussions about the things that actually really matter and weren't discussed with you at the time of your diagnosis. And clearly, that's it's really, really essential that things are talked about openly when people are given options about what sort of treatments are available and what things might happen with different sorts of treatment. Absolutely essential piece of information and set of information. And particularly when it comes to things like sexual dysfunction, which aren't easily talked about by many people. And when I came to one of your support groups, there were two things that I really, really noticed, is that firstly, there was this very large group of men and their wives who are having an open conversation about sexual dysfunction. Now, a lot of people don't have those sort of conversations in private, let alone in a very public forum. Can you just talk a bit about how it's been to sort of generate those sorts of conversations?
Yes, I think, as a matter of fact, Monday we had one of our Oxfordshire Prostate Cancer Support Group meetings, and knowing that we were having this webinar today, I spoke to the gentlemen that have gone through treatment. And I said exactly the same thing to them, that people don't talk about the sexual side of things, but this is my take on it. The fact that any treatment to do with the prostate, even if it's only just female hormone tablets, there is an issue. So I said, the next stage of that is, I expect most of you in this room are taking antidepressants because you've got this mental awareness in the background that you're not a normal human being. You can't, do what you used to do. Would I be right in asking you if you would put your hands up if you're on these tablets? Every hand went up, and it knocked me back a bit because I didn't realize it was as bad as what it was. And somebody turned around to me and said, "Are you not on these?" And I said, "No, I'm not." I said, I could very easily have gone into that. But I said, what has kept me going is keeping myself busy to the point I run my own business, Oxford Office Furniture, and I'm working at it 10, 12 hours a day, even 74, going on 75, because by enjoying what I do at work, and I do enjoy it, I embrace it, it actually keeps my mind off the fact that I can't make love to my wife. It's that serious. But I feel for those guys that aren't busy and have to go down antidepressant tablets.
So there's a really important message there, isn't there, about working with men in a very open and honest way about some of the things that are always challenging for people to talk about. And that includes professionals. You know, professionals, not all professionals are entirely comfortable about having the sort of conversations that you're suggesting absolutely need to be had, so that people can make informed choices, so that people can think about, how do I manage my life going forwards? And for you, that is very, as you say, very clearly sort of being very occupied and you know, being very involved in work, but actually making sure that people have some options around the sorts of ways that they might manage.
I think that the real problem is, and I don't want the medical people to take this the wrong way, but they don't actually know what happens. So lots of people listening to us today, I didn't realize this, I didn't know that. And perhaps they rethink when they're talking to their patients, to actually be honest, you know, talk about it, because people need to know. They can then make a decision. Had I known what I know now, I may have not have opted to go for treatment, because I would have probably gone and said, actually, we won't do treatment. I'll carry on till I die, whilst I can enjoy life. And that is a really big point.
And these are very personal decisions, and the way in which people approach them has to be informed by as much information as can be given, and given in a way that people understand, and that they can then take action on and make informed decisions for themselves.
Absolutely. And I also think that what people don't understand is, in the main, so to make you feel sexy, for the male, he has to have lots of testosterone. So lots of testosterone is a good or a bad thing. Well, it is a good thing if it doesn't go wrong. But as soon as you start taking treatment, female hormone situations, it's to kill the testosterone, because the testosterone actually feeds the cancer. So I'm now in a situation where my PSA, luckily, 10 years after giving the all clear, which was actually last weekend, my PSA is 0.28, which is really, really good. But also it's telling me that I've got no testosterone. There isn't, as far as I'm aware, anything else I can take to boost a sex ego, even although I can't have intercourse with my wife, make me feel sexy enough to make her happy. I'm being honest.
No, absolutely. And I think that the real sort of important takeaway from this discussion is that these are really fundamental parts of people's lives. People have very different approaches to their own sexuality, how they feel about their sexuality. For some people, it's very important. For other people, it may not be so important. Depends on their life circumstances and who they are. But what is important is that people understand choice and understand sort of implications of different sort of courses of action. Dave, I'm just aware of that.
Can I just say a major point, really? There is no website, as far as I'm concerned, that I can go on to address the points that I've made to you today. So, okay, we've got PC UK and all those other sorts of people, but those people that are actually suffering with the erectile dysfunction can go in when there's updates and everything else to try and help people. It'd be lovely to do that, to actually set something up like that. I think it's very necessary, actually.
Yeah. Okay, I think that's a really interesting point, and actually some of the things that some of the people that are listening may want to take some of that away as an idea. Dave, thank you so much for your very frank conversation.
I would just like to say a big thank you to you and your team. It's been fantastic to be able to tell everybody the way it really is. Whether they can cope with the fact of the sexuality bit, it's important they should.
Very, very personal decisions, and the point is that it's that conversation that allows people to make choice. Okay, Dave,
thank you
very much.
Thank you.
Let's go now to Veronica. So Veronica, delighted to have you here. Veronica's the director at Healthwatch Oxfordshire, and is going to talk a little bit about some of the work that they've done.
Yes, thank you. Sian, if you could just make the next points come up, because it's one of those ones. Yeah, thank you very much. Back again. I'm from Healthwatch Oxfordshire. Just to give you a quick brief, Healthwatch is, every area has a Healthwatch. It was set up in 2012 under the Health and Social Care Act. Our remit is to listen to the voices of the residents using health and care services, and to bring their voices into influencing the way services are commissioned and delivered to bring about improvement and change. We're a critical voice, a critical friend. So the next slide, please. So the way we do that, the way we hear from people is through huge range, and all health watches are different in the way they approach that. We use surveys, focus group feedback. We go out and about, we're on the streets, we set up pop-up stalls, and we work through voluntary and community sector. And we also visit health and care settings. But what we do is take what we hear in the form of reports or other formats into, for instance, the Health and Wellbeing Board, and also to directly influence service providers and commissioners. Thank you. But as we all know, and partly why we're here today, there's challenges in making sure that everybody's voice is heard, and men are a particular example of that group. So over the years, we've changed and adapted the way we've developed the way we reach those more seldom heard voices. One way in which we've done that is to develop what we're calling, community research approach. And you can see there's a link there. We've sort of crystallized that into a model, and it's building on participatory inquiry approaches that are well known. But that's a way of involving communities in identifying their own issues and working alongside to support them to find solutions and to bring their voices to the forefront. And we do that working with community researchers as individuals, or also through community groups, and then also asking community researchers themselves to look at specific issues of interest that we're interested in. Thank you. So I've got two examples of the way we've worked with men. This one here goes back to 2018, but it's a really nice example of a sort of collaborative approach working with a group of men under Oxford United Football Club. We supported them through our project fund from beginning to end, taking them through a research process. They came to us because they were concerned about the differentials in health outcomes among men, and particularly Black, Asian and minority ethnic men in Oxford. The disparity between the richer areas of Oxford and the poorer areas was about 15 years at that time. They were also concerned about low uptake of NHS health checks. So we worked with them over a year to sit down, look at what they wanted to ask, design and develop questionnaires, paper form, and we took that to out and about using their WhatsApp networks, using the football teams. So they brought together over 200 men from about 26 different nationalities in regular football team leagues. So this was a fantastic opportunity to ask those men and work with them to identify what some of the barriers were to seeking health and support. So Sian, if you'd like to show the video, I think that's much better explaining the work than myself.
Okay, I'm just going to think we've got it here. Can you see that okay, Veronica?
Yes.
We'd seen a report in a local newspaper about the difference in men's health between those men that lived in North Oxford, which is more prosperous, compared to those men that lived in South Oxford, and how men in South Oxford have high rates of diabetes and stroke, particularly Black and Asian and minority ethnic men. We noticed that the NHS health checks were being advertised by some of the taxis in Oxford.
I'm not thinking it's driving always Cowley Road, but our peoples don't know about anything. Then why can we just, make a questionnaire that ask the people?
We came up with the idea through just discussions that we were having with our friends and colleagues in barbershops. Men are more relaxed in terms of talking about things that they don't normally talk about, like things like, their health. And we found out that people didn't have any accurate information. They weren't aware, basically, about NHS health checks.
We find that majority that we talk to don't even know at all. And that's what starts us to think about it. We need to give awareness to our communities.
We'd already run a community cohesion football tournament through our links with different community groups.
We know the communities that join in and communication come from a different nationalities. Then we thought, wow, why can we not just do something like this in June, in the same week for Health Week?
And so then we thought, okay, why don't we develop a men's health football tournament to promote and raise awareness around men's health?
Said, wow, this is a good thing. We need to do that. And then we publicized it, talked to all our colleagues, all the teams, and we had 24 teams.
Through the men's health football tournament, we'd use a questionnaire and find out through that survey what are the barriers to men enjoying good health, and also what the awareness was around NHS health checks.
Never see any advertisement about that, because maybe most people are not aware.
They didn't know what the form was, what the NHS is all about. And nobody comes to them before and speaks about their health.
The cost of living in Oxford is very high. Everyone's working 2 jobs, full-time job, part-time job.
So they need to look after their families, working, earn their money.
I think that they don't access these services because they probably don't know about it, or they don't realize that how much help there is out there.
Is you might look fit in terms of your physical ability or whatever, and you might not be fit inside. So if you don't go to check for the internal aspect, well, you might not know what exactly is going on.
I mean, the job can find another job. Everything else, you can replace it. Your health, you can't.
A massive thank you to the men who went out of their way to work on this report and develop it to us and present it to us. So it's going to shape the future of the NHS Health Check programme. And now it's for us as the system to come up with some solutions to that.
We've been able to establish as an outcome of the Men's Health Project a diversity football league and continue our community engagement and promote men's health in Oxford.
Thank you. If you want to move on 2 slides now.
Good morning. By show of hands, which I can't really see.
Sorry, that's very strange. Let me just work out why it's playing this.
Okay.
Okay, I think that's better. Are we back now, right?
Yes. Yes, so just to move on to the next slide. Yes, so as you saw from the film, and you can read in the report, we identified some of the barriers that men were facing to looking after their health and to also to accessing NHS checks. So that was sort of time, caring responsibilities. Men were working multiple jobs, working daytime and evening, and also just elements of trust and wanting to be able to access some services or in more community-based settings or faith settings. So some of those recommendations came out in our report. These things take a long time to build an influence, but we're pleased to see in 2023 in January, a new supplementary NHS check service was commissioned in Oxfordshire, taking on some of those recommendations and bringing NHS checks into community settings. So here we can see that, you know, collaborating with people to look at their own issues really brings some of the richness of those voices, but also can help find solutions to that. So if we go to the next slide. So another more recent example of the way we've worked, which isn't community research so much, was going out and about on the streets. And that was building on an initiative by the Oxfordshire Men's Health Partnership, which was 30 chats in 30 days over November. We sort of extended a bit longer. We went out to Carterton, and our aim was to find working men to speak to. We chose Carterton because there's issues of some lower health outcomes for men in certain areas, but also it's an area where there's quite a few industrial estates. So we thought we'd find working men in those environments. We went to betting shops, cafes, vape shops, car works, tire manufacturers, metal workers, and also just coloured people on the streets. It was really great to have conversations with men, and they were all really, really willing to talk to us. And we just asked them about what were the barriers to looking after your health. So men told us that it was getting easier to talk about their health and well-being, and that was particularly for younger men. We found that male friends and men in workplaces were really important to men in enabling them to start to share some of those things that were going on with them. And we came across some really good examples of workplace peer support that was taking place, particularly like around sharing health information and around weight loss and getting fit and that sort of thing. Hobbies were a huge part of men being able to come together and share experiences by doing things alongside each other. So not directly talking to each other in a group sort of thing, but just sharing activities and being able to talk in a low-key way. But we found there was much less choice there for younger men to find those sorts of groups and activities, particularly if they didn't engage in sport. So next slide. We heard, and again, you can see this in the report, some of these sort of things that Sharm was talking about. Men do still find there's pressure to be strong, to man up, to carry on when talking about their health and their well-being. A lot of men would say they would just work through illness, and it was seen as weak to sort of take time off from work. There were barriers to looking after health and well-being. Cost of living came out quite strongly. Men didn't always know where to turn to look for care and support. And there was a sort of younger generation of men who seemed to be quite out of the loop of it was surprising really with the internet world, but sort of out of the loop of knowing where to go to get sort of an isolation and loneliness element came out there. Men told us they didn't want to be a burden, and there was a lot of sort of courage that it took men to get to the health professional in the first place, and their first interactions sometimes put them off and meant they didn't return particularly they spoke around navigating receptionists and appointment systems, but also speaking with health professionals who used confusing medical language, and some men felt they were sort of embarrassed that they didn't understand that, or belittled. So next slide. Yeah, so that project has led on to further work by the Men's Health Partnership, and they're looking at doing some more targeted work in that area around men and men's awareness. So these slides just really are to reiterate that sort of need for continuous ongoing dialogue in the way that we listen, learn, build relationships with the people who are using services, so that we can have more appropriate and responsive services. And I hope these two examples help show that a little bit. Okay.
Veronica, thank you so much. That is a really nice summary of the sorts of things that are really important for services to understand about how men think and feel, so that actually we can do things that actually make it easier for people to come forwards when things aren't right for them, or indeed to come forwards for preventative health checks as well, to make sure that people, we pick problems up early so that they are more amenable to treatment or intervention. Thank you. I'm now going to ask Paul to, oh, there he is, yes, he's appeared on my screen. So Paul is the Professor of Nursing at the University of York, and Veronica, if you can turn your camera off, we'll hand over to Paul now. Paul is going to talk about his experience of research and involving men and attitudes that men have. So over to you.
Okay, good morning. Oh no, it's the afternoon now. Good afternoon, everybody. It's nice to be here. My name is Paul Galdas. I am a Professor of Nursing at the University of York. I'm a men's health researcher. I've been working in the field of men's health for 20 years, almost 20 years. My background's as a nurse. I did my degree in nursing in Birmingham in the late 90s, and worked in coronary care, looking after people with heart attacks and acute coronary syndromes, later working at St James's Hospital coronary care unit there. And that's where my interest in men's health originates from. I used to look after a lot of younger blokes, or what I used to think were younger blokes, and now same age is probably about what I am now, who I found had often delayed seeking help when they got chest pain, and that obviously had a big impact on their prognosis and also what happened during the acute phase of their illness. So I was really interested in some of the reasons why this happened. Why was it so common for a lot of the men that I looked after to have this experience of having symptoms, but waiting until the absolute last moment to go to the doctors or to call an ambulance, something that Sian outlined right at the beginning of the session today. And since that time, I've led a number of different studies with men of a range of different conditions, examining A, what's their experience of living with these conditions, and B, how can we make health services more appropriate, accessible and engaging for them, so that we can overcome that problem really of barriers to uptake. So I've done work of men with diabetes, with arthritis, with inflammatory bowel disease, depression, new fathers. And based on the experience that I've gained over the years, I've shared top tips and insights on how to design services to a range of different audiences, because I found that services are often designed based on a few good ideas or reflect local service need, but there's often been a bit of a lack of an evidence-based approach across the piece, and we haven't been very good at sharing intelligence in men's health. So I've recently written this up as an article, because that's what academics do, I suppose, and that's the basis of what I'm going to share with you today. I've boiled it down into 5 key issues, 5 C's, which are intended to be practical guidance and principles for helping with the design of men's health services. And the 5 C's represent different phases of program design. And also, importantly, there are opportunities in each of the C's where men can get involved in advising and supporting and co-producing design, delivery, and in research as well. And the intention here is to be able to use this as a bit of a framework when teams are developing services or tailoring existing services where there's a need to better engage men, to help give a bit of structure to the overall process. So I'm going to briefly talk through each of these 5 C's and provide a few real life examples, both from work that I've been involved in and from work that others have been involved in the field of men's health. So the first C is co-production, and this can be defined as the overall strategy and process for partnering with key stakeholders and end users. And it's really an overarching principle. And as I said, it should inform activity across all of the other C's and extend not just in relation to design, but also delivery, evaluation, and sharing of information. And the advice here is that the co-production strategy needs to be planned. It ideally needs to be written down, shared, and agreed with everybody involved. It's not something that really should just happen organically or by accident. It needs to be planned strategically how it's going to happen. And another critical point here is that it really needs to consider the needs of a diversity of men and reflect the different gender norms that exist across different groups of men. Men are obviously not just one homogeneous blob, and uptake in co-production exercises historically, though, has been led by men who were already enthusiastic and actively involved. And we really need to do better at that and work harder to purposefully seek out hard-to-reach groups and those that might be most at risk of the health issue that we're particularly interested in, whatever service it is that we're delivering. And best practice is to take a whole systems approach to co-production. So not just gathering a group of men and speaking to them about their preferences, but speaking with institutions, workplaces, religious groups, community leaders, and engaging them as well as individuals. So, for example, in the current study that I'm leading, which is called BARM, it's a mental health intervention for men working in the NHS. We've taken a co-production approach that not just involves men working in the NHS, but also unions, wellbeing services, integrated care systems across the whole system. In a cardiac rehabilitation project that I led, that we involved the local Sikh temples and elders, and in a project that colleagues are leading in Canada with Indigenous men, they've engaged with the elders within that community as well. So all examples of multi-level co-production, which is it leads to the best possible service design and outcomes. Cost is the second C, which is something that often people don't think about, particularly at the beginning of a project or at the beginning of service design. But it also it relates to sustainability, scaling, and also measurement of change as well. And this really does need to be considered early and discussed with partners and stakeholders. It should involve not just the costs for starting up, but also for sustaining. And one of the things that we see a lot in men's health is really great ideas that spring up in response to local need, but then they fizzle out because there's no sustainable funding, or that they live and die with the enthusiasm of a group of volunteers. Evaluation is absolutely key here, and speaking with men and end users and service partners around what outcomes are of interest and how we can appropriately evaluate things to show that they are successful is absolutely key. Another thing, example here on the slide, is that commercial partnerships have not often been exploited in men's health to good effect. So, and it often feels uncomfortable for us working in the health space to think about commercial partnerships, but it can be a way of finding mutually beneficial, sustainable partnerships. So it's been used negatively a lot in men's health, so partnerships with betting companies and alcohol, but it can be used positively, and Dove is one example of that, who are doing work around fatherhood and paternity. Context is the third C, and that relates to understanding environment, setting, location for services, and crucially, thinking about and working with end users and men. How do those factors shape norms around gender and then influence health-related behaviours, and how those can work positively towards increasing engagement? So we know that community-based programmes delivered in men-friendly spaces outside of traditional primary or secondary care areas have been shown to be particularly beneficial and particularly useful for marginalised groups of men who may have a particular distrust or be less comfortable in traditional healthcare environments. So examples that I've put on the slide here include the use of barbershops, online spaces, religious venues, the football fans in training weight management programme delivered in football stadia, and the use of professional sports clubs and sports has been the vogue thing that's been leveraged in men's health at the moment. So not just football, but rugby in Canada, ice hockey in Australia, Aussie rules has been used, but we really need to exercise caution with that. It can exclude men who are not interested in sport. I think this is something that was spoken about in the previous seminar on mental health. But it also can reinforce the restrictive gender norms that we need to be seeking to overcome in the design of tailored interventions for men. Fourth C relates to content, which is about style, mode, and mechanisms of programme delivery, something that I think Veronica touched upon when thinking about the men's health check interventions that have been designed locally in Oxford. It also relates to what is involved in the actual intervention, the mechanisms, and previous work that I've done, for example, in men with long-term conditions, found that a lot of men are put off by support services for conditions like diabetes and arthritis because they mostly involve talking and sharing experience, although Dave's experience shows that actually that can also be done well when it's done and facilitated in an appropriate way. But a lot of the evidence suggests that men find interventions more appealing, and Veronica touched on this, when there's some sort of activity involved that can help men develop partnership, camaraderie, and then conversation can happen shoulder to shoulder rather than necessarily face to face. So using hobbies or interests as a hook to get people engaged can be really useful. And what we've seen that across a range of different hobbies, not just sports, but woodwork, music, cooking, gaming. And again, this needs to be informed through a co-production process and working closely with service users. But really good examples are the Men's Sheds Association, which people will probably be familiar with. And there's a November funded intervention in the Northeast at the moment called Men's Pie Club, where men get together and make pies, which obviously has some other health implications as well. It's mostly about social support. But the point there is it doesn't just have to be about physical activity, it can be about other interests as well. Final C is communication, and that relates not just to how we speak and interact, but also the non-verbal, the written and the visual approach. Key things to consider here are around programme labelling, marketing, and making sure things are understandable, accessible and inclusive for men from diverse backgrounds as well, and adopting a style and expression during the process of the actual delivery of the intervention that aligns with the target group's preferences. So Veronica touched on this in relation to a barrier that many men have around speaking with their GP or accessing health services, is how they perceive they might be spoken to by health professionals, that they might have done something wrong. And so meeting men on a level can often be a really easy and simple way to improve engagement. And in the current study that we're doing right now, we worked with men as stakeholders a lot to get the wording and the language right in the materials that we've developed around, and that's particularly important in mental health, particularly because of a lot of the stigmas associated with some expressions of low mood and anxiety. So there's a lot of evidence of supporting the use of non-technical, non-jargonistic conversational approaches, being frank, direct, honest, using colloquial language, sometimes swearing can be helpful. Again, working with stakeholders for appropriate use of that, but we shouldn't be afraid of that. But the final point that I want to make in my presentation today is that we need to be cautious always, but particularly in communication, but across all these aspects, that we don't inadvertently reinforce the damaging ideals around masculinity that can be the root of the problem in the first place. And the example of the poster in the middle of the slide here, which was from New Zealand and to promote uptake of sexual health, sexual transmitted disease screening, is a really good example of that. Whereas it led to a 5-fold increase in men seeking uptake of STI screening. It's been criticised for promoting toxic aspects of masculinity, and we need to think more broadly around long-term change, around promoting more safer sexual health practices, for example, in men, and not just looking for easy, quick wins. So that might be something that we might pick up in the Q&A. So that's it, Sian, I think, for my presentation. Just put my details on there, because I'm very happy always to hear from people who want to hear more.
Lovely, thank you so much. Can I invite Veronica and Dave to come back and put their cameras on? That's lovely. So we've had a really sort of broad range of different sorts of approaches and different, different experiences of working with men, from Dave's very personal description of both his own situation, but also of men that he's worked with, to Veronica's very local, sort of hyper-local almost sort of, engagement with men and the sorts of things that people are saying, to Paul's broader perspective on, a fair amount of, maybe a lifetime of research in men's health. I don't know, Paul. So anything that strikes you, and we've got a couple of questions that I'll come back to in a minute, but anything that strikes you at the moment? One of the things that comes up regularly, and indeed has come up this time, is the sort of sticky sort of terminology. So I and my team tend to refer to seldom heard groups rather than hard to reach, because it tries to take the problem, it tries to own the problem, to say actually it's groups of people who are seldom heard because we don't go and talk to them, and we don't go to talk to them in the right way, in the right place, etc., rather than they're hard to reach. They're not hard to reach, we just don't do it right. I mean, but some people are expressing a sort of difficulty with the seldom heard term as well. I mean, does anybody have a sense of what we should be saying about who we're talking to, or just not make any comment about it and just say we're going to talking about men?
I think that's a fair point, Shanna. I think I used the term hard to reach, and I've had discussions like that in the past, saying that these groups are not harder to reach. We just have historically have not been good at reaching out to them. The problems with us, not with those individuals, which I think applies to a lot of aspects around men's engagement, is that I think probably 10 years ago plus, a lot of the focus was on men's poor behaviour and the challenges around trying to change that. But really we need to think about how can we design services such that they are more appropriate and accessible for men generally, but also for specific groups, because we know that men do care about their health, they do want to engage and will attend services when they are appropriately designed. And we shouldn't also, I don't think, be afraid of tailoring particular services to particular subgroups, and however I prefer not to get bogged down necessarily in the language that we might use, whether it's seldom heard or hard to reach, but thinking about who's most at risk, what is our intention in reaching, in designing services to reach that group. rather than thinking that we can design something that's going to meet everybody's needs. They won't. So yeah, in Dave's group, there'll be guys and couples that are going along there absolutely really enthusiastic about it, and that's great. But then there'll be some that aren't, that perhaps want a different type of service. But Dave shouldn't feel bad about that, and thinking that he needs to do everything. But we should be upfront and acknowledge it openly, I think. Yeah.
I mean, does that make sense, Dave and Veronica? It certainly came up in the men's mental health that the men is a very big group. There are a lot of different sorts of men. So, Dave, yeah.
I think that I get it, but I think we ought to put more emphasis on the family, the partners, the wives, because they're equally involved, and that's the whole shame of the whole thing. As I alluded to in the early notes, and I did say, being diagnosed with prostate cancer, was I lucky or unlucky? And I think that it's an important point, because we need to get the understanding from the wife, the partner, before a treatment choice is made. I think that's vital.
Yeah. And that's a really important point. And I guess there's sort of two things within that. There's firstly, how do we encourage men to come early when they've got symptoms, or when they're worried about something, or how do we get them to come for prevention screening? So how do we get them to come to their health checks?
Well, I think it's shock treatment, to be fair. So I say to guys now, it's not about having a finger up your bum, excuse my French. It's about having a blood test, and going along to the doctor, having a blood test. And invariably, the GPs, they're general practitioners. I've got nothing against them, but they're not trained necessarily in these sorts of areas. And I say, if you haven't heard back from the doctor within 4 or 5 days, phone up the surgery and ask them what the situation is. And you will get an answer. And the answer you're likely to get is, there's not a problem, the blood tests were okay. That is not the answer that they're looking for. The answer they're looking for is, what is the PSA number? So the blood test is just like any other normal blood test, but that blood test, you then record it, because we know every man will have prostate cancer by the time they die. They probably would never even know about it, but you can then monitor the history, the histolics. So the next, let's say you have a blood test, if it's under 4, it's okay. But if it's approaching 4, book another one in 12 months' time. And then you can monitor the progress of how fast that prostate cancer is actually growing. That will then help inform decisions later when you're a little bit older and it's getting up to, say, if it's over 4, you would normally get looked at or go further. But you've actually got the history. So people don't understand, you get prostate cancer, you get aggressive prostate cancer, and me being me, I was the lucky one to have very, very aggressive prostate cancer. So with me, I went along to the doctor, had a blood test, and it come back at 5.2. So the doctor did come back to me and said, your PSA level is a little bit high. I'd like you to come back in 6 months' time and have another one. And unfortunately, I had a brain tumor in the meantime, and I went back in 8 months, and it went from 5.2 to 10.1. So that's when we had to start having, further tests and everything else. That's what happened.
Yeah, and I think that really, really important messages in there, which are that actually it is always worth following up and not just relying on the system. There's something, that actually, that to understand what's going to happen if you have a test, to understand how long the test result is likely, how long it's likely to be before you get a result. And that's something everybody can ask, even if they're not given that information immediately. So you can ask, when will my result be back? And if you
I think that the message I've got across today, I'm sure that the majority of people were not aware of what it really is like. So the only way to get people involved, whether it's the guys or their wives, turn them along with a bloody lead to the doctors to actually get the test. It's the message I'm saying. As soon as you start treatment, even if it's female hormone tablets, you lose your erections. That hopefully, if we get it out there in the media, will get guys into the doctors to get them tested. But when they go to the GP says, well, actually, there's no need to give you a PSA test. We hear this time and time again. And I say, go back and tell them that your grandpa's had prostate cancer, and they'll give you the test. It's so sad.
So the really important message is for people to go and have that conversation, and to not be put off by any worries about the test or any worries about what it may or may not show. Is to go early, have the test, and have the conversation. And I think that somebody put in the chat, and I'd be really interested to see what Paul and Veronica think about this sort of, how do you make men enthusiastic about looking after their health?
By telling them that they're not going to be able to make love anymore if they don't.
Well,
I'll just come in there with an example of two men we spoke to in Carterton. One of them, we asked them, you know, what would make you look after your health? Do you look after your health? And he said, oh, I know everything about looking after my health, but I don't, you know, I'm not bothered. I'm not going to do that. I'm happy with my life as it is. And I know I drink too much and I smoke and this, that, and the other, but that's my choice. So that was one example. And the other example was a man who was only sort of in his 30s, had acid reflux that he thought was a heart attack. And that had given him a huge scare. And out of that, he had gone to the doctor, realized it wasn't a heart attack, but had significantly changed his lifestyle there, and started to, within his workplace, they'd all joined, rather than going out for a drink after work, they were now all going to the gym. So there's two sorts of contrasting examples there about, you know, and people do have choice, of course. And they, you know, generally people do have the information and understand what living a healthy lifestyle is, but there are those, you know, there's all sorts of barriers in the way to enacting that.
Paul?
Yeah, I think men do care about the health. I think it's a bit of a myth that they don't. Although that being said, I think in the World Health Organization's report on men and gender, they attributed 50% of premature death in men to lifestyle-related behaviours that were associated with gender norms, which are smoking, drinking to excess, physical activity, and not promptly accessing health-related services. So it's there is work to be done there, both I think at a societal level and at an individual level. I think it's a problematic road to go down to focus just on the individual, to think, well, you know, these men within my area, they're not turning up, they don't care about their health. They do, and we've got a lot of evidence to suggest that they will engage and that they do want to take positive actions around the health, whether that's in relation to the you know, the sexual aspects of the health for something like prostate cancer, or whether that's reducing the amount they drink or making positive lifestyle behaviours. So I think we need more policy approaches, I think, both locally and nationally, don't we? And I think it's a real shame that at the moment we have a women's health strategy where right at the beginning it says health services have been designed by men for men. That's just not the case. Certainly there's been sort of a lot of gender bias in health research and health delivery, but currently not been designed for anybody, I don't think in particular. There's not a particular gender bias. So I would really like us to think more routinely about gender as a determinant of health health behaviours and uptake of services, both men and women, in the same way that we do socioeconomic status, age, ethnicity. We understand those things might influence different patterns of health and health behaviours, but we don't necessarily think about it in relation to gender, and a lot historically about men. So I think, yeah, it's
and then, I mean, there's a really important piece in that which sort of picks up on things that all of you have said around sort of how to support the conversations that as I say, it's not, I think that men don't care about their health, but make them more enthusiastic about being active about their health, in a sense. Yeah. And how you encourage those local conversations, and you know, and what are the roles of different parts of civic society or the health and care service? You know, how do we generate some more of those conversations?
Yeah, and I think part of the problem is that historically men are not socialised to speak openly about health related issues in the same way that women might be, because of some of the natural points of health service interaction that women have over the life course, due to, you know, reproductive events, as an example.
Is that having babies, Paul? Sorry. Productive events, having babies and having
babies, starting your periods, all of the whatever it might be, you know. But so I think it needs to start with kids. Is my view, and in promoting a different way of integrating health as being associated with being a man in our society. We can only do in the longer term by helping our children to be socialized in that way, that as a man it's in the same way as a woman, it's important to be open about talking about how you feel and aspects of both your physical and mental health, and I think in that way we will be able to promote positive change for everybody.
Yes, and there's a really important component about thinking about how we work with children or with young people. I'm not sure that I haven't seen any local work, but I expect there is somewhere. I don't know if you've come across anything, Veronica, with work in schools, particularly sort of focusing around some of the health literacy angles for boys in particular.
I'm not particularly sure myself. I haven't really at the moment, no.
So
I'll give you another example, Sian, that covers that I talk about in some of the sessions that I do on this with our public health students around how dominant ideals of masculinity can inform gender-related, health-related decisions. Eating is one. So as a man, there are norms around what's appropriate if you go out with a group of friends to order food or to drink. So if I sit down with a group of friends and we go to a pub and I think, well, I'm just going to get the salad today, there will be some response to that in a lot of situations. That's not appropriate. What's wrong with you? Why are you doing that? We're all getting burgers, or we go for a curry. That's normal. Or I'm going to choose not to drink tonight. I'll just get a mineral water or a soft drink. Again, there are expectations. Those things are changing, but I think being able to openly discuss those and then openly challenge them in terms of what's appropriate behaviour is one of the ways that we can help health and healthy behaviour become more normal and appropriate and acceptable for men. And that's just one example. I think that those things occur across a range of different areas.
There's a question in the question box here about health checks in employment, and I'm just wondering. There's somebody's expressing some concern that maybe people would be worried if they had a health check in their workplace because it might then get fed back. So there's, you know, something about sort of the importance of confidentiality and, you know, people knowing what information goes where.
Well, I think in Oxford, the barriers we saw to health checks weren't just about place or venue, they were about information and timing and those sorts of barriers as well. So it's about a more flexible opportunity for men to access those things.
Yeah, I think that's a relevant point actually, and so that's something we've come up against in the mental health intervention that we're delivering in the NHS right now, is that the men said it absolutely can't be linked with our occupational health record or on our HR file, and so it does not work. If men sign up to receive our mental health intervention in the NHS, it doesn't go on their Occu Health file. But I think workplace set should be seen as a setting rather than a responsible point of delivery by the organisation itself to help overcome some of those issues. But again, that's a really good example of how co-producing services with local service users can help unpick issues like that. Because if you are a blue-collar worker working in, you know, an Amazon factory, for example, picking that out of the air, other services available, but you know that might be a real issue for you. But if you're working in a different organisation, such as my own, for example, that won't be a concern for me that my organisation might think that. So I think again, kind of working with end users to try and identify what might work, what might not, where are the barriers, and how can we overcome them is really important.
Yeah, Dave.
I'd just like to pick up on some comments that Francesco has made. Number one, he's saying, or she's saying, that the webinar has lost its delivery in their opinion because there's no interaction with the other people that are on site. The other point they brought up was the fact about I read it that myself to get the permission to do the type of things like I've done today. So my view on both things. Number one is I've got nothing to hide. I don't need to get any agreements or okays to do what I'm doing. I'm an individual. I'm allowed to do that. And I think that perhaps the important point is if this wants to be taken up and people want to have another video conference, if you can organise it, Sean, particularly about the items which I've discussed, I think it's a brilliant idea where everybody can interact on it. And that will help put something together, video together, that we can get it pushed out there. So I just thought I'd add that before we finish.
Thank you very much, Dave. Yeah, I mean, there are limitations with all formats of having discussions. We run workshops and we run webinars, and they are different. And some of the things we do, we run as workshops, and some of them we run as webinars. And that's the sort of distinction that we make for some things. And you know, we've run workshops about this sort of conversation as well. So it's, yeah, we do both, and they are different. I'm just, one of the questions was about whether people had got any experience of getting men more involved in their local surgeries discussions, you know, so the sort of patient participation group model. And I don't know if anybody's been involved with patient participation groups, or Veronica?
Yes, we have. We do support patient participation groups and network them. And one thing we do also is patient webinars, similar information webinars, which, and I was thinking it would be great to bring Dave in to do one of those patient participation webinars. We haven't focused particularly on men within those. So.
Yeah.
I can come in there. We've done this many times, both at all sorts of places. So if we take urology department at the Churchill, we used to set stands up there, but we could not. So it said Oxfordshire Prostate Cancer Support Group, but we couldn't approach anybody. They had to come to us. It was all very difficult. And we also give packs out to all the patients. so that at least they've got the details of who we are and what we are. But I think that what we need to do is reach out to people before they even have to go to the Churchill Urology Department. That is the big key.
Yeah, absolutely. And so that is about really trying to support these conversations about health in general, so that actually people feel like it is okay to be a man and make their health important, and then therefore sort of take action, as opposed to just being important as a sort of general thing. And that means that they hopefully would be more likely to present early, so that some of the challenges.
And there's definitely a role for PPGs, isn't there, in this education, you know, educating the wider patient audience and running, you know, health and well-being days. Some of them run that. So if they focused on men's issues, it would be really good.
Yeah, agreed. We're just coming up to about sort of 5 minutes before the end of our time, and just a sort of really brief sort of summary. I mean, we've heard, I say, real spectrum of ideas and experiences, which essentially say, as I sort of take away, that there's something about the way that we bring boys up, and something about the way in which society says you can be a man like this. And whilst that has broadened, I think, certainly since I was, in the 70s, there is a breadth of what being a man is like. There's still a fairly sort of core bit of that isn't necessarily particularly helpful when it comes to thinking about what it means to take care of oneself. And I use that sort of term advisedly, because actually it's not about whether or not one's health is of interest to one. It's about actually looking after oneself, taking care of oneself. And the sort of predominant model is usually that men are supposed to take care of their family by providing and all that. And that, whilst that seems deeply old-fashioned, it's still out there. So there's something about how we have the conversations that shift some of that. And that is partly what we do ourselves, and partly what we do with our colleagues, and what we do with our children. Then there's this whole space around trying to support not just sort of boys learning about these things, but how to have those conversations with men in places where men have conversations. And that shoulder to shoulder image I've always really liked. It's about, sitting in the car and having a conversation with somebody is very different from sitting and doing this, even, let alone sitting on a sofa. And it is fundamentally different, where there is something associated with the conversation, which isn't just, I'm going to have a really important difficult personal conversation with you. And of course, the nature of healthcare is that is almost how it's set up. So there's something about encouraging those conversations elsewhere that mean that when somebody comes to have that conversation face to face or online with a professional, it is an easier conversation to have. So there's something really important about how we all act towards each other to support those sorts of conversations happening. And then there's that sort of broader piece about how do we continue to have lots of local conversations. How do we continue to do research that supports us to understand better how to have the lots of different nuanced conversations with different types of communities or different groups of men. So I'm just going to say thank you all very, very much for sharing your experiences, and particularly today for sharing things that people don't usually talk about, and really important that we do. Just to say that this is the last of the two in the men's health series. I think that we put the link to the mental health webinar in the chat, and we will you're on our list now, so you will find out what we're doing next. But this will hopefully be a continued conversation as opposed to a sort of an end of a conversation. So again, thank you all very much to the participants who have put sort of all sorts of interesting comments and questions in, and hopefully we'll see you at our next event. I'm not quite sure when that's going to be yet, but we will let you know. So have a nice afternoon, enjoy the sunshine, and keep talking.